today. So welcome. Today we are going to be talking about utilizing psychological autopsies and mortality reviews to inform suicide prevention efforts. My name is Jessica Rose Johnson, and I'm a project associate here at SAMHSA's SMVF TA Center. And I would like to welcome you to this webinar and spending time with you today. And I'm going to pass it over to our amazing federal partner, Ms. Andrea Lee.
Hi, everyone. Thank you, Jessica Rose, and good afternoon or good morning. My name is Andrea Lee. I'm with VA's National Suicide Prevention Program, and on behalf of VA and SAMHSA, want to welcome you all to today's webinar. We're really excited to have a star-studded panel of subject matter experts here with us today to talk about this very important topic. We know that there's been a lot of interest in how to start a mortality review committee within your states and communities. And so we're really grateful to our SMEs for sharing their insights and their lessons learned with us today. So without further ado, thank you all so much for being on today. And thank you to our wonderful speakers for sharing your expertise with us. Thanks, Jessica Rose.
Thank you. So as she said, we have a wonderful panel lined up for you today. You're going to hear from 4 amazing people with great experience in their fields. And I'll be introducing each of our speakers right before their presentations. So some basic things, as all of us have been on Zoom for quite some time now, I think we're very familiar with how the mute and unmute buttons work. If at any point in time you have any questions, feel free to put them in the chat. We will be doing a Q&A at the end of our sessions, and we'll be gathering those questions out to make sure they get answered. Now, as always, we do have our disclaimer that the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services, the Veterans Health Administration, or the U.S. Department of Veterans Affairs. Now, on to our presentations. We're going to be starting with the wonderful Dr. Stephanie Gamble. She serves as the Deputy Director at VA's Center of Excellence for Suicide Prevention, where she directs the Education Division, which implements the national training, which is designed to prevent suicide amongst veterans. She's also an Associate Professor of Psychiatry at the University of Rochester Medical Center. And as the Director of VA's Behavioral Health Autopsy Program, she brings a wide range of expertise. Her research and training interests are improving care for individuals with co-occurring substance use disorders and depression. She provides mentorship and program evaluation, behavioral health, treatment research, gender-focused interventions, as well as treatments for co-occurring substance abuse disorders and depression. She had her doctorate in clinical psychology from the University of Buffalo, which is where she still lives today. And you can often find her in hockey rinks during the nights and on weekends, cheering on her 2 wonderful sons. So if everyone would give a nice warm welcome to Dr. Stephanie Gamble.
Thank you so much, Jessica. And truth be told, they're not always wonderful, but I can be found in hockey rinks. It's a prerequisite if you live in Buffalo. But thank you, everyone, for just the invitation to be a part of this panel, and to all of the state delegates who have taken time out of your afternoon to join this panel discussion about how death investigations can be used to help inform veteran suicide prevention efforts. Next slide, please. During this part of the panel, I'm going to describe psychological autopsy methods, and we're going to discuss how these methods fit within a public health approach to suicide prevention. And I'll share some examples from VA's Behavioral Health Autopsy Program to illustrate this. And then I'm going to round out my segment by highlighting how psychological autopsies can complement the work of mortality review teams. Next slide. Okay, so let's start with psychological autopsies. The term psychological autopsy was first coined by Edwin Schneidman in the early 80s in the seminal article that described a method to determine the mode of death in equivocal cases. This really grew out of a need in the LA County Medical Examiner's Office to make determinations of death and to investigate intent when trying to distinguish between natural, accidental homicides and suicides. So what Schneidman did that was so revolutionary was that he described this systematic method that could really get at the psychological and contextual circumstances that preceded deaths thought to be suicides. And another kind of novel piece about this work is that he included in the method an opportunity to interview one or more informants. These were typically individuals who knew the decedent well and could help kind of get to that question of intent. Next slide, please. In recent years, psychological autopsy as a method have been used in postmortem studies of suicide. Sometimes this involves only looking at records alone, but more often, what makes psychological autopsies kind of special is that they include information from a variety of sources. And in particular, they include that interview component. Next slide. So let's talk a little bit about these two different sources of information. We'll begin with records. So the choice of records that you might want to include in a psychological or a behavioral autopsy can depend on the population under study. So for example, if you are investigating adolescent deaths, you might want to include school records in addition to health records. For older adults or for a veteran population, you would want to include health records from the systems, health systems in the area, or any records that would include mental health records or physical health records. Now, there are some challenges not only to obtaining records, but for making sense of the data once you have access to those records. So certainly these would include things like navigating the complexities of HIPAA, obtaining permission and proxy signatures, releases of information, and Dr. Rep might go into that a little bit more. Variability in documentation. So sometimes you get records within one health system where you have conflicting information from different providers, or you might have variability in documentation across different health systems. That can sometimes result in asymmetry of information. So it's helpful too when you're setting up this record review to have clear processes and documentation for how you're going to resolve when you have discrepancies from different data sources, or perhaps you have information from one source, but that information is lacking from another source. One other key piece of information about records is that it's important to recognize that availability of records is not independent from mental health and medical morbidity. So there are certain conditions or types of treatment that have special protections. So access or availability to those records in the case of substance use treatment or HIV status, that can complicate things further. It's also incredibly helpful, and this was outlined in Schneidman's original work. It's important to use a standardized abstraction approach. So if you have a standardized template, or if you have clear recommendations or processes for how the information is going to be abstracted, that can be exceptionally helpful. Next slide, please. In terms of the interviews, particularly the timing of interviews, most experts recommend 2 to 6 months following a suicide, although these recommendations can vary. Sometimes investigators have approached family members or next of kin within 1 month. Other times it's up to a year, and sometimes even more than a year if there are concerns about bereavement. Next slide, please. So now let's spend a little bit of time talking about how psychological autopsies, or how this surveillance methodology might be helpful within the context of a public health approach to suicide prevention. And I can imagine each of the states are working through many of these steps now as you craft state-specific plans for reducing veteran suicide. Next slide, please. So within the Department of Veterans Affairs and the Veterans Health Administration, the public health approach that VA uses, surveillance plays a key role. And I think in some ways the role is most obvious when you look at these first 2 steps of the public health approach: defining the problem and identifying risk and protective factors. So each year, VA publishes an annual suicide data report. And oftentimes the data that's included in these reports use data from the National Death Index. That data, I think, can best be construed as sort of the top of the iceberg. It gives us a good sense of the size or the magnitude of the problem in terms of the number of veteran suicides or the rate of suicides. This kind of information can also be helpful for understanding the magnitude of problems in particular states or counties or even communities. Where psychological autopsies, or in the case of VA, behavioral health autopsies come into play, is that they can provide detailed, rich information about what lies beneath the surface. It's the who, what, where, when, and how of those suicide deaths. So when we think about VA's behavioral health autopsy program, think about kind of the bottom part of that iceberg that might not be immediately obvious from the numbers, but that exists nevertheless. Next slide, please. Okay, so we're going to spend a little bit of time talking about VA's behavioral health autopsy program, because I think in many ways it provides a nice example of what Schneidman talks about on a much larger or national scale, especially within the context of veteran suicide prevention efforts. VA systematically collects information for all veteran deaths by suicide that are reported and known to VA clinicians and suicide prevention coordinators across the country. And just like what Schneidman recommended in the early 80s, it includes information from two important but distinct sources: chart reviews and interviews with family members. Next slide, please. The chart review component of BHAP uses a standardized web-based chart review template that assesses the types of things that you would typically see in a medical chart or a medical chart or electronic chart. Demographic characteristics, case information about the death, service utilization, so things like number of visits, number of no-shows, services provided, number of encounters. It also includes clinical diagnoses and symptom severity. So this could include things like DSM diagnoses, ICD-9 codes. It could include symptom severity from standardized screeners like the PHQ-9 or PTSD screener, but it also includes risk and protective factors that you can only get by detailed reviews of progress notes, looking for things like hopelessness or interpersonal problems, legal troubles. Next slide, please. To complement the chart reviews, if you could go back one more. Yeah, exactly. Thank you, Jessica. To complement the medical record reviews, our team in Canandaigua also completes family interviews, which are semi-structured interviews with veterans next of kin that are identified in their medical records. And this tells us a different perspective. From talking with family members, we get a good sense of the context of the veteran's life prior to their death. And oftentimes, family members' stories go beyond what you would see in a medical record. And really, it allows the family members to tell the veteran's story from their perspective. Next slide, please. And what we do within the behavioral health autopsy program is we put these sources of information together. The more quantitative categorical data from the charts with the narrative descriptions and more qualitative data that's available from the family interviews. Next slide, please. So to give you an example of this, I took lethal means data from both the chart reviews and the family interviews. And one of the reasons that I picked lethal means is that I know it's a priority area for state teams across the country. And many of you are working on action plans to specifically address lethal means in your individual states. So these data are from a little over 3,000 chart reviews that were submitted between May of 2017 and May of 2020. And looking at the chart reviews, specifically the case information provided in the chart reviews, we see that the majority of all veteran suicides were reported to result from firearm injuries. Now, this percentage is consistent with what we see in the suicide data report. We also saw that death by firearm was the most common method for both male and female veterans. Next slide, please. When we looked at the chart review data across all the different age groups, younger veterans, middle-aged veterans, older veterans, firearms were singularly the most common method used across all these ages. But something interesting occurred among the older veterans, age 75 years of age and older. Firearms among these older veterans were used in 84% of suicides. So this gives you a bit of that under the iceberg information about lethal means used in veteran suicides that are documented by suicide prevention coordinators. Let's turn to the family interviews to examine lethal means data from a different perspective. Next slide, please. So the family interview data, and these are data collected from 404 family members in that same time frame from 2017 to 2020. We asked family members the degree to which their loved one, the veteran decedent, had access to or owned a firearm prior to their death. And family members reported that over 3/4 of veterans had access to or owned a firearm. Family members of veterans who are age 75 years of age or older reported that 100% of those veterans, so 100% of their loved ones, had access to or owned a firearm. Next slide, please. So putting those data together, combining data from those two sources, we analyzed the data a little bit differently. Among veterans who had access to firearms, the most common methods were here, we see that percentage jump to 84%. So let me repeat that again, because I think it's important. Among the veterans who had access to or owned a firearm, 84% of them died by firearms. 7% died by hanging and 3% died by overdose. Next slide, please. So within the public health approach, and this is where psychological autopsies or data becomes even more important. It's not just about categorizing the who, what, when, where, and why. It's about using that data for action. And that's what each of you are doing in your state teams. You're learning and discussing ways to use data that you're collecting on the state level and the county level and the community level to translate that into targeted actions to prevent veteran suicide. So this example with the lethal means data helped to inform a policy recommendation or a practice recommendation to extend lethal means safety training to providers across a variety of clinical settings so that it's not just a mental health issue, especially those clinical settings that involve older veterans and female veterans. Next slide, please. So again, in that same vein of using data to inform suicide prevention efforts, you're going to hear from the next series of panelists about mortality reviews. And there are some great, I think, overlapping commonalities between psychological autopsies and mortality reviews. 3 of which are that both involve in-depth reviews of individuals who have died by suicide. Both types of processes involve multiple sources of information and standardized processes. And both share an objective to understand the context and precipitants of suicide to inform targeted suicide prevention efforts. Next slide, please. The ways that they differ are that oftentimes within psychological autopsies, the term is used to describe a methodology. Sometimes a methodology is used in research. Sometimes it's used as part of a surveillance program. Oftentimes it's used to inform policy. But the power of mortality reviews, and I can imagine this is going to be underscored in the next series of presentation, are that the review teams are often composed of diverse stakeholders in communities who are in positions to drive change across key community sectors. So you have the people at the table who can really make change locally in communities or even statewide in communities. Next slide, please. So I'm hoping that this presentation gives you a little bit of information about psychological autopsy, how VA is using our own version of the psychological autopsy, the behavioral health autopsy program, to take perspectives from family members, to combine that with the power of information that's in the electronic health record to really make a difference in preventing veteran suicide. Thank you. I'm not sure if we're going to reserve time for questions at the end, but I've included my contact information here on the slides if you ever want to follow up. Thank you.
Thank you. Yes, we are going to do a combined Q&A at the end, but I have track of all the questions that came in through the chat, and we'll make sure that we continue this discussion towards the end of the presentation. So thank you again, Dr. Gamble. And like I promised, lots of good information that we're going to be sharing with you today. So next up, we have Dr. Rep, who is the Chief Epidemiologist, COVID-19 Epidemiology Manager, Researcher, Analytics, Information, and Data, and Medical Examiner's Office in Washington County Public Health Division. That's a mouthful, but it's because she does a lot of great, amazing work. She has some great publications, like the first ever person-to-person transmission of COVID-19 without direct contact. Her epidemiological methods involved into a community-wide emergency response and the incorporation of the National Violent Death Reporting System into a novel suicide surveillance system developed in the county, which is one of the greatest projects she has worked on and one of the ones that I'm most fond of myself. She's received multiple awards to include the Henry J. Grass Access Award of 2021, and her medical examiner team even won the 2018 Susan P. Baker National Public Health Impact Award for their efforts. Her research interests include injury and forensic epidemiology, outbreak investigation, so you can imagine COVID, and suicide investigation. Her doctorate in microbiology she earned in 2005 from Arizona State University. And she's madly in love with her new baby Weimer, Maverick, who you may hear snoring behind her, but don't mind him. He's just a baby resting up. So, Dr. Rick.
Thank you, Jessica Rose. I appreciate it. And yes, he's asleep right now. So God willing, we will make it through the next 20 minutes with him continuing to sleep. So today I'm going to talk a lot about data and how data are used and making sure the data you are looking at are answering the questions you want them to answer. So I'm going to talk a little bit about suicide fatality review in Washington County. I'm going to talk about our surveillance system. I'm going to talk about the medical legal death investigation system and sort of tie it with what Dr. Gamble just spoke about the different sources of information used in both. And on top of that, other information sources that are available to describe suicide. One of the things that is unique about my position at Washington County is that I supervise the medical examiner's office. And that has allowed me access to our medical legal death investigators and going to a lot of death scenes in Washington County, which has completely changed the way I look at data as an epidemiologist. And I'm going to talk about that a little bit. And I'm also going to go over some of the states and jurisdictions that have been trained or are lined up to be trained in the suicide fatality review process we developed in Washington County and the surveillance system. So I understand that the majority of people here today represent states, and that's great. I'm from a county in Oregon, and we have just under 700,000 people, which is considered a large county, but it's much harder to get data down at that local level. So the sources that I'm showing today, some of them do have data at the local level, like the county level, but most of them are at the state. So suicide is very complex, right? There's not one set of data that will answer all your questions, that will point to where you need to go and give you your interventions just in one shot. That's not a thing. You have the actual mortality, like Dr. Gamble said. You have your vital statistics, a simple description of age, race, ethnicity, manner, means, those kind of things. And that's great to know. For example, non-Hispanic white males over the age of 65 are at the highest, have the highest rates of suicide, but that doesn't tell you what to do about it. You have morbidity. So the aspect of suicide are the attempts and the self-injury associated with suicide. The ideation, so the mental health aspect of it, including substance use, and the comorbidities and protective factors. So comorbs, as we say in the business, are basically multiple conditions that someone might have. So for example, if I am going to a death scene and I have a 90-year-old woman who has high blood pressure, breast cancer, and a kidney disorder, those are all comorbid conditions. So age is high, et cetera, et cetera. So again, a very important aspect of suicide is looking at any of those comorbid conditions that are in place at the time of the death. Like Dr. Gamble said, you know, this could be something like, it could be something like a recent divorce or, you know, a traumatic event. That they can, in addition to physical health aspects, there can be behavioral aspects that are comorbid. And of course, protective factors. Now, if anybody knows anything about suicide data, well, we don't collect anything positive. Actually, that's probably the truth for all data systems. I mean, in public health, we simply measure the bad things, but it's also important to measure protective factors so you can enhance those. So the data sources I have lifted up here all get at different aspects of suicide. We have the National Veteran Suicide Prevention Report that Dr. Gamble mentioned. It's amazing. I love it. It's really, really detailed. It's great. You have your BRFIS for your mental health aspects. You have student wellness survey. For example, if you want to know about your 8th and 11th graders, how many of them are having ideation in your state, you know, getting to for that sort of predictive behavior that's associated with a death by suicide. If you want to look at the actual injuries, so for example, if you want to look at firearm versus hanging, for example, you can do that in Whiskers. And of course, the SAMHSA Behavioral Health Barometer is amazing. That's really great at the state level. If you want to look at that, it combines a bunch of different sources in one to sort of give you a nice summary, doing a lot of work for you to show you what the status of behavioral health is in your community. Now, this is not an exclusive list, of course, but these are the quote unquote heavy hitters, I would say, with the exception of the National Violent Death Reporting System. So every state now participates in the National Violent Death Reporting System, NVDRS. Oregon was one of the 5 or 6 founding states. So we have data from 2009 forward. And the National Violent Death Reporting System is considered the gold standard for violent death information. And what does the NVDRS collect? So they collect as much information as they can from the local jurisdiction on law enforcement, death certificates, ME or coroner reports, anything they can basically get their hands on, they will incorporate it. And they were the first, this is the first surveillance system and the only, to my knowledge, that's actually done something like this. And there are over 600 data elements are captured, and that is no joke. They have a coding manual that's 500 pages long. It is the best coding manual I've ever read, and it is beautiful. And it gives examples of this counts, this doesn't count, and to allow this information to be captured. Now, of course, everything is either a yes or the no and unknown are combined. So that's it's basically a prevalence table, if you will. So we can talk about the prevalence of physical health problems, intimate partner violence. Now, this system relies on the local health jurisdiction to send this information to the state so the state can send it to the CDC. Now, as we all know, when you make a copy of a copy of a copy, the information loss occurs at every single step. And part of the work that we've done in Washington County was to actually put some numbers on that sort of data loss from the death scene all the way out to what came out of the CDC. And I will go over that in a moment. So the NVDRS is amazing. The limitations are it's supposed to be a state-based surveillance system. So if you want information for even a smaller jurisdiction than that, it's pretty challenging to get that. And the newest data available are 4 years old. So that's kind of, that's reasonable because it does take that long to collect everything. So best case scenario, you're looking at state-based data that's 4 years old to describe your suicide issues that also rely on people voluntarily without funding, send them information for all the deaths by suicide. So being the weirdo field epidemiologist that I was, or I used to be, I went over to our medical examiners and I said, hey, can I go to a death scene with you? And after having a psych eval that was over 3 hours long for simply asking that question, I ended up going to over 200 scenes with our death investigators, and now I supervise the office. So what I learned from that experience as an epidemiologist was profound. So I had seen the data that come out of vital statistics. We've all seen that, the age, sex, etc. I had seen what's come out of NVDRS, so a description of the physical health problems or the prevalence of mental health diagnosis for Oregon in terms of people who died by suicide. But I wanted to follow the data trail all the way to the source to see what's there. What is, when the information is quote unquote the most pure, has not been copied of a copy of a copy, there's no information loss, what do we know? And I was absolutely overjoyed as an epidemiologist to see that every question I could possibly want to know the answer to data-wise was already asked as part of a standard death investigation. Everything I wanted to know, the public health gold, the prevention aspects, the risk factors, the comorbidities, they were already doing all that work. So the problem was, why isn't that information getting all the way out the end? And there are multiple reasons for that. One of them is the medical examiners are responsible for reporting what's forensically germane. So although as a public health person, I am very interested in the fact that the person was living in poverty. If that did not forensically contribute to the manner and cause of death, that's not going in their narrative report. And so lots of things like that happen. So I wanted to find a way to capture all that information at one time from the death investigators. So that's how we developed our sort of novel surveillance system that Jessica Rose mentioned a little bit. And what that is, it's a sort of data collection instrument that is filled out by the death investigator within 24 to 48 hours after the death, assuming the death decision does not rely solely on toxicology, because that can take 6 months, but for the other deaths. And it turns out that who asks the question matters. And what I mean by that is there is a considerable data loss between the person who did the death investigation and when it comes out of the CDC. And so what I did is I looked at 133 suicides in our surveillance system versus the same data for the same suicides coming out of the National Violent Death Reporting System for Oregon. Now, if the answers were the same, which is what would be ideal, there would be full overlap in the bars. And as you can see, the gray bar surface, our suicide risk factor surveillance system, has a very different prevalence of these risk factors in place. For example, on the top row, you see our investigators said 80% of our deaths by suicide were experiencing a depressed mood, whereas what came out of the NVDRS was about 55%. The most striking, of course, is the second one, recent crisis. Now, this is what really changed the game for me. So coming out of NVDRS, it was about 10% of our deaths had a recent crisis, and out of our, the investigators, is about 71%. So as an administrator, I would make very different funding decisions based on 71% versus 10%. So that's a very big difference. And the reason why that was in place, so we looked into that very heavily, it's because the investigators would observe a crisis. So they would say the person had a DUI, the person was losing custody of their kids, they just got a terminal cancer diagnosis, a point event that that person's life is now defined as before that thing that happened, before the event and after the event. That's the definition of a crisis for the terms of the surveillance system. And the medical examiners were writing out all these crises in their narrative statements, but they were not perceived to be crises by the abstractors for the surveillance system. So that was pretty interesting. So we did this to see if we wanted to keep our surveillance system, because if it wasn't adding anything, then we don't need to do it, right? Well, it is. So not only did I get near real-time data, so this is for my county, 24 hours, 48 hours after it happened, done by the person who actually did the death investigation, and seeing the significant difference in results for the same suicide. So we have kept our surveillance system and used it to guide our work. And as I said before, no one system will get you all your answers. This included. This will not get you all your answers, but it does really help you narrow down between this and vital statistics, sort of the risk profile. So for example, now that we've been collecting data with our surveillance system for every suicide since 2014, I have a profile for Vietnam era veterans. I have a profile for female veterans. And every risk profile is different. And so that's why, the VA comes to me and says, what are you seeing for female veterans? They have all their information that maybe I don't have access to, but I can share mine and say, this is what we are seeing in our deaths based on the full death investigation. I see, I don't want to say the wrong risk factors, but I'll mention the exact risk factor. We've had people ask our community organizations, what is the profile for African-American suicide in Washington County? And we can answer that because we have this and it's fresh data. So that is really actionable. And again, when you try and look at all suicides at once, you really lose the granularity of different populations. I mean, of course, a Vietnam vet is going to have a very different risk factor profile than the 17-year-old in high school, right? They're going to have different risk factors. So you can't treat all of suicide with a one size fits all. And this gets you a very specific profile to help work with. Now, the other aspect of what we do is a suicide fatality review. And as Dr. Gamble said, that is not a psychological autopsy. So it is after the fact, but it is with consent of the family member, not with involvement of the family member. That's kind of the difference. So our suicide fatality review, we request permission from the family we, as in the county medical examiner's office, request permission from the family to review the case. And as we assemble a group of stakeholders, we've got law enforcement, we've got VA, we've got FBI, we've got religious leaders, we have crisis line, we have all these community members, organizations at the table. And what we do is we send out the decedent's name and date of birth, and we say, okay, do you have anything in your system on this person? And then we meet for suicide fatality review. And everyone, the medical examiner presents the case, and then each organization presents their information that they might have. So for example, the crisis line might say, I had 3 calls from this person's cell number over the last 3 months. Or the VA might say, this person is not a veteran. Or, the FBI might say, for example, the social media on this account was getting very morbid over time. Everybody brings a different aspect to the table. So that information may or may not have been available at the actual time of the death scene investigation, right? This is 2 months. And so after we go around the table and everybody adds all their additional information, we focus on what system level interventions could be in place to prevent a death like this one. So no longer focusing on that specific person, but someone with that profile, for example, what could we put in place to help this stop happening? Some of you may have seen some of the more unusual things. Trust your data. If you can trust your data, you will go to interesting places. We found people were dropping their pets off at the animal shelter before they ended their lives. We found specific locations that were independent of means and vital statistics and all those things that people were going to die. And we found these really sort of bizarre patterns, if you will, that there's nothing about that in a suicide prevention manual. It's not a national best practice. Nobody has collected that information, yet these patterns are all there. And sure enough, when we pushed down on those hot spots, our suicides rate went down. And when I say push down, I mean go to all those places and train the staff, like the hotel staff, the animal shelter staff, in question, persuade, refer. and empower them to do that. We've seen, we went from, Oregon had the 8th highest suicide rate in the country, and my county's rate was higher than that. And now we're below the national average. So, I mean, it has been an astronomical change between having the surveillance data to inform the suicide fatality review and having all the right people at the table for the suicide fatality review. Again, that can actually guide those interventions. So the family members are not at the table for this. This would be incredibly traumatic. Obviously, we wouldn't do that, but they give consent for this process to happen. So other states and jurisdictions that have either this full suicide fatality review and the surveillance system, or one of them, got a lot in California, New York, Wyoming, Nebraska. Right now, I'm working with the Mental Health Services and Oversight Accountability Commission in California to work with LA and some rural counties. We've done training at the Portland, Oregon VA, and we've trained in academic settings too for medical providers, healthcare providers, Johns Hopkins, our School of Medicine, and the Wyoming Primary Care Association. So again, this is not just about public health coming to the table. This is about everybody coming to the table that has a stake in suicide and empowering them to take action within their own community. So this is my contact information if anyone would like it, and thank you for listening.
Thank you so much for sharing. And again, if you have any questions, if you want to throw them in the chat now, I've gathered the ones that have come in during the presentation and documented those, and we'll work through them on our Q&A session. So next up, we have Mr. Carl Ralston, who is the Suicide Prevention Coordinator for the Montana Department of Public Health and Human Services. He provides evidence-based programs to all of Montana's secondary schools, implements the Suicide Prevention Plan, supports the Montana Suicide Prevention Lifeline, implements firearm safety programs and statewide media campaigns, provides suicide prevention trainings, coordinates suicide prevention efforts all across the state. He's also an adjunct faculty member at the Montana Law Enforcement Academy, and he's nationally certified to teach question first aid and referral, as well as mental health first aid. He's a licensed clinical social worker who maintains a small private practice in Helena, Montana, with a master's degree in social work from the University of Denver. Now, as we talk about some fun facts to share, everybody always wonders and wants to visit Montana, the wide open ranges, the beautiful landscapes. Well, he shared a fun fact about Montana that 46 out of the 56 counties are considered frontier counties with an average population of 6 or fewer people per square mile. So if you want some open range to live life and enjoy, feel free to go visit Montana. In the meantime, we were going to pass it over to Carl Ralston to share some life with us.
All right, thank you very much. And so a few things that I'm going to be focusing on is our suicide mortality review team, which was formed in 2013 out of a legislative bill that was passed, and it allowed us. I think we were the first state in the country to review every single suicide that occurred in the state of Montana, not just veterans, but in the entire population. And a little bit about really how that has evolved is that we started off by getting all the death certificates and then requesting coroner's reports. But then we would send out questionnaires back to them, which was really focusing on obtaining information about mental health issues, toxicology reports, relationships, criminal behavior, if they've had any previous suicidal behavior, chronic pain, all sorts of things to try to start to develop a picture of what was happening with the people that died by suicide. And really what I'm going to cover today is we're going to talk a little bit about how we use that data to gain knowledge and impact change in our society, our culture in Montana, of how we use data to really enhance suicide prevention efforts. It really we started to notice a connection with law enforcement, because in Montana, about 90% of coroners are law enforcement. So how we're starting to partner with law enforcement. And then, of course, it also helped us as far as our work with veterans and SMVF population. And then a little bit about, just want to finish just talking about funding, because that's always a concern from folks. So when we talk about the nice thing about what we have found is that it probably gives us the closest thing to real-time data when it comes to suicides in our state. Because in Montana, death certificates are required to be submitted to the Department of Public Health within 10 days of a death. And what happens is that any death certificate that has been identified as a suicide immediately gets forwarded to myself. And so every Friday I get all the death certificates for the previous week to 2 weeks. And I'm able to collect about 16 to 18 different data points on every suicide. This information is also shared with our NVDRS team, which is something new in our state. We were one of the last states to get on with the NVDRS. Also, it really helped us work with the VA in that what we were noticing when after about the first year of doing the mortality review, we were noticing that the numbers that our VA had for suicides was much lower than what we had. And so it allowed us to start to share information. We got an MOU in place to share data with the VA, because that meant with our numbers that were higher, that meant there were families that weren't receiving resources and services. And so we really wanted to make sure that that was addressed. When we talk about as far as how it has really enhanced our prevention efforts, our team, after a 3-year period, came up with a number of recommendations based on our findings. And not surprising, a lot of them fit in with what most of you know are national resources. But really, we really found the value in identifying the mortality review team and continuing that. Now, what that did prompt us to do is become part of the NVDRS. For whatever reason, Montana had been resistant to becoming part of the NVDRS for years. Our review team, I think, really prompted them to see the value in this. And this is one of the reasons why we continue. It's one of the reasons why I continue to review all suicides that occur in our state. But as I mentioned, it also started to help us identify programs. And one of the things, especially with kids that we found, is that we were also kind of tied in with the FICMR teams, the Fetal Infant Child Mortality Review. And I would be part of any review of any suicide involving the youth. And what we found is that for many of these kids, they were lacking coping skills, resiliency skills, conflict resolution skills. So that really prompted us to start to promote programs within our school system that enhanced resiliency. One example of that is, for instance, using a program like the PACS Good Behavior Game in our elementary schools to start to develop and enhance social and resiliency skills in our kids. We also, one thing that makes us a little bit different than NVDRS is that we are also able to get health records. And what we found is that for many of the health records indicated that even if the person was on a SSRI for depression or anxiety, many times there was not any type of screening being done. And so this really prompted us to get on board with the Zero Suicide Initiative and Suicide Safe Care, and really working with organizations around the state, healthcare organizations, to really encourage primary care providers to be training in suicide risk assessments. It also, of course, one of the things that we did is we broke down the data, and all the things that we looked at in the general population, we also broke down to some of our high-risk populations, such as veterans, children, and our American Indian population. Our American Indian population, although it's very small in number, is almost double to triple the rate of suicide, especially for young American Indian males. And so we really wanted to encourage that we needed more coordination and more programs for American Indian youth. This is something that we haven't had a lot of luck in getting the actual position, but what we were able to do, and based on the knowledge that we were able to collect from the mortality review, is to get some SAMHSA grants around zero suicide for American Indian adults. And so we have a grant manager who works with tribal health in all of our reservations and urban Indian, really promoting universal screening and the Zero Suicide Initiative. Also, it really brought out how much of an issue firearms are. You heard earlier from Dr. Rep concerning around the number of suicides by firearm for veterans. In Montana, for all veterans, it's about 77% of used a firearm. But in Montana, 86% of all firearm deaths are suicides. And it's about 63% for our kids. And that was alarming, because that's much higher than the national average. And we're not talking about hunting rifles and shotguns here. 89% are handguns. And so this has really prompted us to really start more of a declaration around safe storage and getting gun dealers and families to understand around making sure that if they have a family member or a child that's experiencing any type of mental health issues, to really lock up and temporarily store firearms away from them. It also brought out the issues of the mental health issues. And what we were finding is that many times these kids were not, especially in rural communities, were not being seen by pediatricians. Many of them had histories of depression and anxiety. And so it really prompted us to start to take a look at screening in schools. This is one that we've had a number of bills that I've started to go through, be presented to try to get screening in schools. Haven't had much success as far as getting the bills passed, but what we have been able to do is it gave us an opportunity to collaborate with the Montana chapter of the American Academy of Pediatrics, where we're starting to promote universal screening among pediatricians and nurses. And so this is something that we've really started to push and continue to push heavily in our state. Probably one of the best things that's come out of our review team is that it has allowed us to provide resources to survivors. We take a look at much of the research around suicide survivors. Many times families don't get resources for 1 or 2 years, if not longer. So one of the things that we are able to do is that based on the death certificate, when we got a death certificate and we were able to identify next of kin, we immediately send a letter to the family that was from me, inviting them to contact me if they wanted to. And we haven't had a large response rate. I'd say probably about 3 to 5%, but those turn into usually 1 or 2 hour conversations, if not longer. And gives us some of the best information from the family. And it's the family that's choosing to contact us. So we're not reaching out to them, they're calling us. We also provide families with grief resources from the SPRC website. And every survivor gets one of these handbooks that's on the right here, the SOS Handbook for Survivors from AAS. And they're getting those resources usually within 2 to 3 weeks. And we send them no matter what. If the family's in California or Europe, we send the resources to them whatever address we have for them, we send it to wherever they are. As far as the lasting effects that we've seen from our review team, probably the most prominent is that to this day, we just got done with a legislative session in our state. Even in this session, every suicide bill that gets proposed is based on the findings that we had for the review team. And so it's had a lasting effect as far as driving intervention, and the recommendations that we made are still being used by legislators to propose bills. And that is probably one of the best effects that we've had. It also was definitely a catalyst for us to become part of the National Violent Death Reporting System, which I'm part of that board as well. And we're trying to enhance that system as well. One thing I'll go back to on this, one of the things, and this was noted by one of the speakers earlier, is there are gaps. There are gaps definitely within the NVDRS. And I think our review team has been able to help fill in some of those gaps with the National Violent Death Reporting System. And the one that's the most obvious when we talk about mental health issues. When if you take a look at the NVDRS, they talk about 54% of suicides had mental health issues. Well, when we started to train coroners to ask questions, to look for different things, what we came back with was about 83% of our suicides has some type of mental health issue. So I think really it has helped upgrade the training and education of our coroners. Now, it does definitely, as I mentioned before, a majority of our coroners are law enforcement. And so it's definitely helped us as far as making sure that our law enforcement are better trained and prepared. So at the Law Enforcement Academy, we now have all of our officers go through mental health first aid. They go through QPR. We will teach officers and first responders on how to use the Columbia Suicide Severity Rating Scale. We are able to reach out to county sheriffs providing training and crisis intervention training through mobile trainings that actually go out to different departments. But it has really, this is the place where it's really helped and tie things in with the NVDRS, is that because the coroners all are law enforcement, they get their certification at the Law Enforcement Academy. So we've built in training into their certification around asking questions around mental health, toxicology, chronic pain, relationships, criminal behavior, social media. So that's built into their core training at the Academy. And has also given us an opportunity to start to provide training in psychological autopsies. We've been able to bring in people from AAS to provide training to our coroners. And this is something we're continuing to do to upgrade their level of understanding, especially when they're dealing with a suicide, for them to really dig in and be looking for psychological factors. As far as with our SMVF population, the data sharing has been critical. We want to make sure that we have the same numbers and that the VA system has the same numbers that we're having, so that families can get resources and we can start to identify protective factors that could be used in cases, and even geographic areas where maybe there's more suicides. It's also one of the things that's tied in with our healthcare, because what we know in Montana is about only 40% of veterans used VA services. That means the other ones are going to other healthcare systems, many rural healthcare systems. So we've really started, in addition to promoting the universal screening, also ask the question at intake around if you or a family member have served in the military, so we are able to identify families that may be veterans or maybe part of the military that wasn't previously able to be collected. Also promoting definitely the universal screening. We work with primary care settings around the state, tribal health centers, on really using the Columbia, the ASK, safety planning, lethal means counseling, caring contact throughout the systems in our healthcare. And it has also given us an opportunity to look at peer support. One of our counties was able to obtain a grant where they established a veteran peer support specialist program at one of our larger bases in the state, in the VA hospital, and start a pilot program where we started to connect vets with a peer support system. And this is something that we want to, as pilot in one county, but really take it out and have something that's expanded to other counties in the state as well. And it's also given us an opportunity to kind of regenerate interest with the American Legion and VFW, because we've reached out to them, and especially in our rural communities, our really small communities, there may not be a nearby VA health center, but there's usually an American Legion or a VFW. And so we've actually started to work with them on training them in QPR and the peer support piece, where when they hear of a vet coming back into their community, that they reach out to the vet doesn't reach out to them, they reach out to the vet, and they're trained in QPR, so maybe they have some of the ability to recognize the warning signs. Also, it's allowed us to take a look at some other programs, and we want to think outside the box on some of these things. So Dog Tag Buddies is a program that works with veterans that have PTSD, provides them with service animals that help with their PTSD. Well, a lot of these vets, when they are triggered or when they're struggling, may become suicidal, and they're working with these folks from Dog Tag Buddies. So we're starting to train the Dog Tag Buddies folks in QPR, and even in some of them in using the Columbia scale, so they can assess if they're working with a vet that may be struggling. We also work with an organization called the Veterans Navigation Network, and that's really focusing on getting not only just peer support, but certified behavioral health peer support, with the ability to get further certification through the state. But once again, it's really a focus on training the people that work with our veterans to be able to recognize when maybe they're struggling or they're at risk of suicide. And another big thing, and this was actually part of our governor's challenge. We received some funding to be able to implement many of the goals that we had with the governor's challenge. And one of them is to make sure that our 211 referral system was up to date. And that had been a problem. We have more than 95,000 veterans in our state. And many times if they called or contacted 211, the system was outdated. And so we put money into not only updating it, but building in sustainability so that it will be maintained and continually updated, because we found that many times this is where many veterans went to find information. And finally, I want to just talk a little bit about the funding, because when I work, I get a lot of calls from other states asking how much does this cost? You know, we don't have the funding. The most important piece, and I mentioned this at the very beginning, is that it's critical if this is legislatively funded, or I mean passed. You know, that bill really allowed us, gave us permission, gave us the opening to do this. But the money wasn't a lot. When we first started, we were only given about $60,000 to do the suicide mortality review team. And we ended up being able to do it with money left over. Really, the only money was to get the team members together about 6 times a year to review all the suicides. But a lot of it was printing, postage. So it really doesn't take a lot of money to be able to do a review if you have collaboration with your epidemiologists and your vital statistics folks and your coroners association. A lot of this can be done for very little money. So with that, I will end up and we'll pass it over to Dr. Staley, and we'll have questions at the end.
Thank you so much. So next up, we have Dr. Staley, the Suicide Prevention Research Coordinator with the Utah's Office of the Medical Examiner. He's conducted near real-time surveillance of suicide mortality, conducts and oversees enhanced death investigations for individuals who have died from suicide, and oversees accidental drug overdose related surveillances. He's also the principal investigator of the Utah Youth Suicide Research Study, which I know we've gotten many questions about in the past, and holds a faculty appointment in the Department of Psychiatry at the University of Utah School of Medicine. He's co-chair of the American Association of Suicidology Psychological Autopsy Committee and is currently leading efforts to create a new version of the psychological autopsy protocol. He has his PhD in sociology of mental health and illness from the University of New Hampshire. He currently lives in Salt Lake City with his awesome husband. So I will pass it over to you.
Thank you, Jessica Rose. He's not my husband yet. We have about 12 days before that. So exciting things on the horizon. We can go to the next slide, please. One thing I just want to point out before we dive into the substance of what I'm presenting here is that what I've noticed is that Dr. Rep and Carl and Dr. Gamble have all presented a model that get at many of the same things. And so when I think about how this kind of thing might be adapted elsewhere, hopefully those are the wheels that I hope that we're turning today, are what pieces of each model that we're presenting here today might you take to your state or county or jurisdiction and put in place to make something kind of like this or similar to this work. So we can go to the next slide. And so this is where my model is a little bit different. Carl talked about the 56 counties in Montana, I think most of which have their own coroner, and that presents some opportunities and challenges. Here in Utah, we have a centralized medical examiner system. So I think that is one of the reasons why I've been able to be as successful as I have developing statewide suicide prevention. And our state not only has a centralized medical examiner system, but most of our suicide prevention funding is really funneled through our state Department of Substance Abuse and Mental Health, including mini grants and core grant funding to our local mental health authorities and local health departments as well. So there are many ways to do this. And so I've talked to folks in South Carolina, in South Dakota, in North Dakota, other places throughout the country who say, we want to do what you're doing, but we have these other challenges because of a coroner system or because of a hybrid system. And I think the takeaway here is that, for me, is that this is possible to do with the right partnerships in any state. So we can go to the next slide. I would actually just add to that previous slide that because we're a centralized system doesn't mean that it's just seamless and everything happens in one system. We are an office of 10 pathologists, 2 epidemiologists, about 9 full-time death investigators. The National Association of Medical Examiners says that we should have about 29 full-time positions to accommodate our caseload. So there's a huge shortfall there, which we make up with part-time death investigators who cover nights and weekends here in the Metro Salt Lake City area. And then we have about 92 vendor investigators who respond on a per case basis in the more rural parts of our state. And some of them are law enforcement, some of them are EMTs, some of them are neither, and they get pretty minimal training. And so that comes with a pretty significant set of challenges when we're talking about trying to get a solid amount of information on somebody who's died by suicide, particularly in some of the rural places in our state. So I'm a sociologist who's a suicidologist, which I think gives me some license to do epidemiology. I do have a little bit of coursework in epidemiology, but what role would a suicidologist play in a medical examiner's office? And that is really to conduct simple epidemiology. That is to count and gather key demographic and circumstantial characteristics of individuals who live in Utah or died in Utah who died by suicide, and then report those deaths to key partners on a regular basis. Key partners is a pretty expansive / ambiguous term. One of the most valuable partnerships that I think that we've built is between the University of Utah healthcare system and between Intermountain Healthcare here in Utah. And between those two medical provider systems, that covers about 90% of Utahns. So, there's a pretty big footprint there, and we can cover a lot of ground with just 2 partnerships, which is another big advantage of what we're doing here in Utah. We've really pushed our death investigation system, and they are, particularly in the era of COVID-19, they were it was like a flash flood, completely overwhelming our system. And so we've had to think and rethink how we do this, and we're still not where we need to be, but we're moving in that direction, which is to get our investigators to ask the right questions at the scene of a death. Just like Dr. Rep talked about earlier, getting that information at the scene of the death is optimal, but we know that we miss that. We work with 81 different law enforcement jurisdictions throughout the state who typically are first on scene at the death. And sometimes we're not called until, an hour has passed, till their crime scene investigation unit has done their thing. Again, very suboptimal, but a very difficult cultural thing to change. And so our death investigators going to a scene where the family has already left. I'm going to talk about how we remedy that in just a second. And then we conduct meaningful mortality research, we conduct mortality research, and that's the Utah Youth Suicide Research Project, which I'll talk about more in a second as well. The overarching thing, which Carl talked about, and one of the most rewarding and pieces of this job that I value the most is something I didn't fully understand or expect, which is to engage with families and promote healing and prevent negative outcomes. So we first start engaging with families about a day or 2 after the death. From my team, hopefully our death investigator is doing that on the scene. We have a book that they can give to them that's like, step 1, here's what you need to do right now. And then if you flip a few pages, it says things like, you probably shouldn't sell your house until the dust settles, things like that. But we send them a card a couple days after that, and then we are engaging with them over the phone after that and making some really great referrals to resources in our state. Next slide. So I'm going to go through each one of those categories just a little bit in more detail. And the best way to do that is just to provide examples. So you probably were all witness to this COVID craze in behavioral health. That was, if we don't do these mask mandates, or if we do these mask mandates, or if we don't do in-person in school, or if we allow college students to meet in person, you can fit the public health intervention to the threat here in where you live. you know, if we don't do X or Y, or if we do X or Y, then suicide rates are going to go through the roof. And I really resent that very much, that people used suicide, politicians, policymakers used suicide as the leveraging point about to do or to do not in the era of COVID-19. But we could speak to that in real time. And I know that my colleagues on this call share that as well, that we could speak to that in real time. We could go to the governor of Utah, who knows me because of our relationship building over the years. And I can say, you know, our suicide rate has not gone up, neither has it gone down. And so we still have the same crisis that we had on our hands. Perhaps the risk factor profiles are changing during this pandemic, but they're not going up. And so when it came to backing the governor on a mask mandate or other public health intervention, that data was readily available. And there have been other incidences, suicide clusters, for example, when we've been able to speak truth to some really toxic situations, particularly clusters among youth. We were able to say to the media that it's 23 teens did not die in this high school. It was far fewer than that. We made a conscious choice not to share that number. But we knew what was happening, and we knew as it was happening. I also create a monthly report that we distribute to key stakeholders. And one of those things that we do is notify the Veterans Medical Center, Veterans Administration Medical Center here in Salt Lake City, when we have a known veteran or somebody who is receiving services at the VA died by suicide. I also do that for high schools and other public schools throughout our state, and actually private schools too, so that by the time the students arrive the following morning, there is an adequate crisis intervention team on the ground, in addition to the school counseling staff. Next slide. So this is the Advanced Death Investigation System, and Surface and SUDS, SRFSS, which is Dr. Rep's version of this, we just expanded to cover drug overdose, accidental and undetermined drug overdose. And so we had to rename it to get suicide out of the title. We called it Sudden and Unexpected Death Surveillance System, or SUDS, because if you don't come up with these fancy titles, then are you really even doing public health, right? So this is a two-part interview. We usually do this interview about anywhere from 4 to 8 weeks after the death with the next of kin. And I'll caution you, you do lose several folks in this system that are not going to answer your phone, that were on the scene of the death. And so pushing your death investigation bureau to do these things is really important. And we have put that pressure on as much as we possibly can. But we also wanted to make sure that we weren't just losing people because they weren't at the scene of the death, because we know that happens a lot here in our state. So we call them and the next of kin, and we ask them about 28 questions. There's follow-up questions to that. These interviews last, if you're just looking at that section of it, about 30 minutes or so. And then we turn the tides a little bit and talk about how that suicide loss survivor is doing. We have a relationship with our crisis line here in Utah. We have a backdoor number so we can connect and do a third-party warm handoff if we have to. We've called law enforcement when somebody started choking on food. They were emotionally fine, but started choking on food. So we were able to call law enforcement, and they went there and I guess did the Heimlich or something. But we are able to make these really great referrals that are appropriate, that are competent. I know that I'm sending people who are at minimum AFSP trained in bereavement. And so we take all this information that we're gathering, and it really broadens and makes more comprehensive our understanding of suicide in our state. And we take that information. Not all of these deaths get reviewed. There are about 650 suicide deaths here in Utah, and we don't review all 650 of those deaths. We don't have that kind of time, but we do look at pockets of each of these kinds of deaths. All children, anybody under 18 is automatically reviewed. And one of the kinds of fatality reviews that we're doing right now is with our healthcare systems who are engaged in zero suicide. So we look at their patients who have died by suicide, particularly those who were seen in the last 72 hours or 1 month within their death, and figured out what were some opportunities for some intervention from those healthcare systems. And we're also working with our local mental health authority. That's our primary Medicaid a behavioral health provider in our state. Next slide. The youth suicide research study is taking everything that we've done and really turning it up. This is where we're doing these psychological autopsies. So we are doing everything we can to interview the parents of this young person who died by suicide, and then also talking to 2 or 3 of their friends to get the best picture we can of young people who died by suicide in our state. There are about 207 deaths that are included in this study. We're right at the tail end of doing interviews. This has been a very long process, partly because of, like Carl said, we're all working within budget constraints, and we've done this study on bubblegum, duct tape, and dental floss, meaning I've employed the use of medical students at the University of Utah to help me do these interviews. We've trained them, of course, and then they help do these interviews, which, by the way, the byproduct of that is that we have competent medical health, or more competent healthcare providers that are not afraid to talk about suicide, that are not going to leave the bedside because they're simply afraid of death and bereavement. I like that we are exposing medical students to a very real part of life, which is death. So it's been a while. We started doing this in the spring of 2019, and we're just wrapping up interviews, entering all of our data into REDCap, and shortly we'll start basically splicing all of these data, which is the third bullet, the de-siloing existing information and connecting all this information together. A couple of years ago, the state legislature gave the medical examiner the authority to request any state and local record in our state for an individual who's died. So we can request school records, criminal records, medical records. We don't request them, but we could get things like tax records. I just haven't seen the value in that just yet. And we basically de-silo all this information and add it together with our interview data to get this dense, rich data set. And then right now, because we are kind of winding interviews down with the youth study, we're working on getting our veteran study going. And we're going to work in these cycles. After we get the veteran study, at least over the hump, we're going to initiate one for people who are LGBTQ in our state. And also, we're already working on a project that will probably not start until 2024, which is the native version of this study as well. I have a preliminary report due to the state legislature in September, and wish me luck. It is a furious, fiery dumpster fire, if I'm just being, it's not a dumpster fire, but it is a busy time here trying to get all of our data put into our system so we can at least have a preliminary report by September. And next slide. So I wanted to talk a few things about fatality review committees. Dr. Rep has given you some really great pointers. Same with Carl. These states have had some, and counties have had some really awesome things come out of their fatality review committees. I've been part of fatality review committees where things happen, and I've been part of fatality review committees where things don't happen. And perhaps you can relate to that if you're on this call. I disbanded our state suicide fatality review committee when I took that over in 2017. And the reason for that is because that group had all the expertise, and they were producing these really great recommendations to our state legislature, our state board of education, these healthcare entities, EMS, you name it. But the problem is that nobody was taking those recommendations and implementing them in their various agencies. And so to me, what that ended up boiling down to, aside from the amount of time and resources it took to create that fatality and pull that fatality committee off, was simply that we were just closing a whole bunch of PII, personally identifiable information, to people who otherwise would not know that. The point of a fatality review committee is that it has to be data to action. If that action is missing, then start over. And so that's what I did with our suicide fatality review committee, is say, okay, where can we get some traction with recommendations? And at the same time, zero suicide was really becoming the thing. Intermountain Healthcare, huge healthcare provider, when you talk about the proportion of people who they provide services for, came to the table and said, we want to start reviewing deaths within our hospital, but we don't want it to be limited just to our hospital, because we know that our patients are receiving care from places like the VA or from the University Healthcare or from a local mental health authority provider as well. And so we bring all those stakeholders to the table with a whole bunch of Intermountain vice presidents and emergency room docs and heads and chairs of nursing. And we dig through those deaths in great detail and talk about what could have we done better? What things could have been done or were missing? What parts of our protocol were not executed that we just simply need to do the thing we said we were going to do? So we've really been successful with that and already have made some pretty interesting changes within Intermountain Healthcare, which is the one that is the early adopter of this process. And by the way, we're still learning in that process. It's still new. We don't have all the answers. So I think fatality reviews have what I call a replace and repair framework. Repair are the short-term things, which is what part of our current protocols were not followed or not followed to fidelity. That's something that vice president can call up 3 or 4 physicians within their heads of emergency rooms, or the principal social worker in that emergency room, and say, hey, your social workers were supposed to do the Columbia, and it turns out the PHQ2 or PHQ4 triggered that and nothing happened after that. Can you explain to me what happened and how can we fix this problem? That sounds a little punitive, and we've worked hard with providers to make sure that they don't feel like we're going to be breathing down their neck or pointing out, hey, you did this wrong. It's very much a collaborative issue, and we know that everybody can do better. The replace things are the things that take time to get to. These are the long-term fixes, which is that we look at trends. These 3 patients who had these similar kinds of circumstances were homeless. And the thing about it is that this person was discharged from an emergency room or from an inpatient hospital stay, and they were homeless. And that was really the key issue. You can point to the mental health stuff that maybe was in between that homelessness and that suicide attempt. But until you fix that homeless thing, that thing over here, no amount of fluoxetine is going to fix this person's suicidality, period. So looking at root causes and then collaborating with other organizations in our state, like 4th Street Clinic, to get this person sheltered, at least temporarily. So those are the things within fatality reviews that we've been able to do, which is systems approach, I think, and making sure that you have the right stakeholders at the table, the people who, frankly, you might have to push back against. There have been times where there's been people in our fatality review committee who kind of say, like, well, what are we supposed to do here? Just go pick up every person that's homeless and do some kind of psych eval? And you have to say, no, that's not what we're saying. We have to fix this homeless thing when they show up in your emergency room or when they're admitted to your inpatient unit. So it's a learning process and a hard thing for a lot of people, and rightfully so, because it is a very wicked problem. Suicide is a very wicked problem, and it's complex. And the next slide. I really am looking forward to working more in depth with our VA here. We're leaning into these answers. We're developing our protocols. And there's so many good things that have happened with the behavioral health autopsy program in the past. We're not reinventing the wheel here, but the VA is such a great place to do, and VA and other service member serving organizations is such a great way, or I should say a rich place to do a fatality review, because when I look at all of the services that are available, there's so many more places than when we look at Joe Q Public or Ann Q Public that we can build upon and say, this person didn't want this service when it was initially offered, but look, it wasn't offered again and these next 10 visits. So what about, or nobody asks, why don't you want to engage with homeless services at the VA? What about that is scary to you? We learned all kinds of things when we've dealt with the VA in other cases that were, for example, Intermountain Healthcare or University of Utah Healthcare cases that intersected with the VA. And so, like I said, and there are many organizations for vets that don't exist for civilians. And so I'm really looking forward to that process, because I do believe it has just such great contours and is very rich. And the next slide, which is the Q&A. I wanted to give a plug for the AAS psychological autopsy program before I turn the reins back over. The AAS has developed a training that you can take to do psychological autopsies. If you've done that training and have not become certified, I would encourage you to become certified. It really is professionalizing psychological autopsy in some really recognizable and important ways. It says that we will abide by this code of ethics. It says we're going to do these methodological things to ensure that we're doing and producing quality results. And it is a very good thing to do if you're interested in this work. And as in my introduction, we're working on the protocol 2.0. And so that would be, this is now is the time to provide input on that as well. And so if anybody has any questions about that, I'm happy to answer those as well.
Thank you so much. We are definitely going to move into some great Q&A. We've had some coming in through the chat and the open chat, as well as some direct Q&As. So I'm going to wrap us back up to Dr. Gamble. There was a specific question during your presentation that asked about the psychological autopsies, the behavioral health autopsies, if that's done at every VA hospital, and what does that look like? If it's done at every VA hospital, does it route up to the big VA, or each VA handles them differently?
Great question. Thank you for that question, Jessica. Yes. So as part of the behavioral health autopsy program, every suicide prevention coordinator at VA medical centers or large or very large community-based outpatient clinics, those are affectionately referred to as CBOCs within the VA center, each of those facilities and the suicide prevention teams within those facilities is required to submit a behavioral health autopsy program chart review template for each known veteran suicide. Now, both Carl and others pointed out, though, that if you look at the annual suicide prevention report each year, I think the most recent statistics are of the 17 veterans who die by suicide each day, 11 are not enrolled in care. So even though it's across the country at every VA medical center, there are a number of veterans who aren't captured within VA's BHAP program because suicide prevention coordinators just aren't aware of those deaths. But I think the procedures at the state level, certainly within Montana, for that data sharing, the fact that as the suicide prevention coordinator for Montana, Carl shares that information with VA, I can imagine the Montana data is an accurate representation of the deaths by suicide that are occurring among veterans in that state. And if Dr. Staley has anything to do with it, I'm sure that Utah's data looks pretty great as well.
So there's another question that came in. Oh, go ahead.
Oh, me?
Yeah.
Oh, yeah. I was just going to comment that interestingly, there's a lot of unknown when it's asked, was your father, whoever's filling out that death certificate. Here in Utah, there's quite a bit of unknown deaths. In fact, I have it right here for the last 12 months. Unknown is about 5% of all of our suicides in the last 12 months, which I find somewhat interesting. And it's, that if you talk to the VA and identifying these folks as we have, it's that, for example, my grandfather never served in combat. He served shortly before the Korean War, and he doesn't consider himself a veteran, but he did actually serve. And so I'd be really interested to know what my mom would check on that box. But if you look at that difference that 5% makes in our state, that radically changes the proportion of the number of people who've served versus not served. We do these interviews and hopefully resolve some of that, but not all.
Excellent point, Dr. Staley. And I know Carl referred to this in his presentation, but that's a perfect example of why the ask the question that's a part of the governor's challenge is such a, it's a critical priority area, because I think, the grassroots efforts and the connections and the partnership that's needed to make sure that those questions get asked, and that people have an understanding, not only a shared question, but a shared understanding of what that means, to make it more broad.
And I think this next question actually kind of goes out to a few of you. If there is an agency or an organization that is wanting to partner with the VA on these autopsies, how would they go about doing that? So it sounds like there's some state level stuff as well as some federal stuff for the VA. If somebody's wanting to partner to be able to give information and assist.
So we have the Portland, Oregon VA at the table for our suicide fatality review. And I understand that's a little bit different than asking about the psychological autopsies, but even getting them to the table and having data sharing is incredibly huge challenge. Obviously, I think all of us know that. So what we did basically to get them at the table is they came to, our representative came to the table, to the suicide fatality review multiple times and watched the process. Then we had all our confidentiality agreement, the next of kin form consent, all of that gone through legal at the VA. And then after all of that, and that took probably a year before everybody was actually comfortable, and then we could start sharing information. So I would say the most important thing to get the VA at the table from an outsider's experience is patience.
I'll just say that we've been working on a data sharing agreement MOU with the VA here in Salt Lake City for 3 years. So patience, key ingredient. But at the same time, we've looked for opportunities because they know this is their patient, this is our decedent. We have to do a competent death investigation, and they can benefit from that too. So.
And I think Carl mentioned too, so patience, certainly, perseverance, in addition to patience, in making sure that privacy and confidentiality, of course, is covered, but having those MOUs in place, I think, are critical.
We did have a question come in specifically for Dr. Rupp in regards to a copy of the death scene investigation tool, if that's something that you are able to share, and how could someone get a hold of you if they wanted to get a copy?
I'm government, so everything I do is available to the public, literally everything. So yeah, absolutely. We have it in Qualtrics. Dr. Staley, I'm jealous about the red cap, I'm not gonna lie. But we have it in Qualtrics, and I can send you a link so you can play around and tinker with it. If your organization has Qualtrics, I can actually send you the entire survey built, like everything. A lot of states have started doing that just to save you, a year of building it in-house, and that not so yeah, just email me and I would be happy to share all of that.
And ditto to the red cap thing. I have to say this is a grass is the greener story, because I built the thing in Qualtrics, and then then our data security people said, no, you can't use Qualtrics for that because we don't pay for that level of security or something. So we had to use RedCap. But anyway, I'd be happy to share that in RedCap as well. It's essentially the psychological autopsy questions built. We adapted them a little bit for our youth study, but that's what we have now.
So a few variations of questions have come in regards to the COVID-19 pandemic and suicides. There's a lot of misconceptions going around, and I feel like a couple of you might have some feedback and input on that one.
I can go first. When back in March 2020, when the storm clouds were brewing over, at least in our part of the state, and were already raining in other parts of the country, we pulled together some Department of Psychiatry folks, Department of Health, Division of Substance Abuse and Mental Health, Intermountain Healthcare, and started meeting weekly to review the number of deaths and some basic demographic characteristics of those deaths. And week after week, we just saw, actually, we saw a pretty good decline in deaths, starting in late March through May, and then it picked back up. And that ideation and attempts both followed that same kind of curve. They returned back to quote unquote normal after a little bit of a peak in July, and then you even it out. Anyway, some of them, I guess what I'm seeing and what we know about these are people who have long COVID are at much higher risk. I don't have a number there for you yet, but we have seen have not seen people who have been diagnosed with COVID. By the way, that was a question we added to our family interviews right away in March was, how did COVID impact this death? And then, of course, unpack that a little bit. But essentially, that's what we were getting at. And for the most part, the answer was this person really wasn't worried about COVID, and they were going about their life. And this behavioral health thing that was going on, or this divorce that was going on, or what have you, was like so much more impactful than COVID-19. That being said, I don't know that we fully understand, or that survivor fully understands the weight of COVID on top of the divorce, on top of the substance use disorder or what have you. And I'm just thinking that's probably going to be somebody's really great dissertation in 2035. So
I want to reiterate what Dr. Staley said earlier about the politics of this. So I presented on this a little while ago for this group, and the narrative for what was happening for COVID and suicide was written before it had actually happened. I mean, you can find Washington Post, New York Times article, like the suicide rates are going to skyrocket. You know, it was written and nothing had happened. And sure enough, I mean, I'm a county, not a state. We had half as many suicides, half, than we did in regular times. And it's still low. We still have not gone back up to normal. So, and then sure enough, the CDC comes out and says, yeah, actually suicides went down during COVID. So this was the first time that I've actually seen suicide data try and be weaponized for a political agenda on my end. So yeah, it was very important for us to stand up and say, actually, no, here at least, of course, it's not the same for every subgroup, but you know, it didn't happen.
Yeah, and just to add, I mean, last March we were beefing up Lifeline resources and Warm Line and everything in anticipation, and it didn't happen. We saw very similar to what Michael said. We had a little spike in calls in July, and then it flatlined. You know, for our numbers for the state were below the year before. Now I am seeing kind of an increase in the first 6 months of this year. And there might be, and I can't attribute it directly to COVID, but I could see where there's fatigue. There's COVID fatigue from people. I do think the economic piece maybe, but I definitely have seen an increase in the need for mental health services, though, because I'm also a clinician, and working with clinicians, the amount of people that have increased anxiety, circumstantial depression has gone up. So the need for counseling services are there. And that's a problem because there's not enough behavioral health in our state. And so most people are full. So I definitely have seen a greater need for the services, but luckily not a direct correlation with suicide.
The only thing I would add to the conversation is that I think a byproduct of COVID that's relevant to the discussion today is heightened awareness of the importance of real-time surveillance data, and the fact that burden falls on county medical examiners and coroners. It highlights how the public health infrastructure needs more funding.
Absolutely. And that's, if you're going to, and this is where the conversation always starts, I'm sure Dr. Rep and Carl and everybody here is, okay, so you want to start doing this. The step one, call your coroner, call your medical examiner. But the truth of the matter is that they're completely underfunded and they're completely overworked. And so for Joe Q Public, who's random, who, you know, you might have a relationship with the health department, but they're like, look, I cannot do anything else. And it's a really difficult argument. So I'm beginning to think maybe step number one is not your coroner or your medical examiner. Maybe it's your state legislator. Find a champion. Because it, like Carl said, it doesn't take a lot of money. I mean, we're incredibly resourceful people. So.
No, it was really just having permission to have access, and you know, the legislation allowed us to have the death certificates, and we ended up, I think in our state, we even ended up improving our death certificates because they added things to it, which then makes it just a standard. I think, and then just giving the access to medical records, you know, so doctors always worried about HIPAA. And so, but having that legal legislation in place that allowed us access was greatly, greatly beneficial.
With that, there was a question that came in. Since, Mr. Austin, you live in such a wide open space, was there anything that you saw as a disadvantage or advantage to those services and resources? Because you're sharing with families when someone passed away. Is there something that was a real disadvantage or an advantage to being such a wide open space of a state?
Well, I think giving them resources, sending them resources was greatly beneficial. But if the family needed to follow up with behavioral health, that's when it became a problem. We have a number of telehealth programs. We have a program called Thrive, where people can use computerized cognitive behavioral therapy. We have actually a collaboration with the University of Utah, where pediatricians can have immediate access to child psychiatrists for consultation, which is critical in rural Montana. You know, we work with the University of Washington on bringing in third-year psychiatry residents for a year. It's not enough, but definitely the lack of behavioral health continues to be an issue. And as people's anxiety and depression goes up a little bit, especially the anxiety, I am concerned about them just not being adequate resources available.
Is that something that the rest of you experience as well in your locations throughout the US?
In Oregon, we certainly don't have, I don't think anyone has enough behavioral health resources, and my investigators don't do anything even remotely close to what Carl or Dr. Staley were talking about. Our centralized state medical examiner's office has made it clear that their job is manner and cause of death. They're not social workers. And we don't have social worker teams outside of the crisis team to actually go with the family and follow up with them and make sure that they're getting their needs met. I'd love to grow in that way, but again, we need some funding to do that.
Yeah, that's a problem. I think you could ditto for Utah. I think this last spring we had 26 open positions on our crisis line here in Utah, partly because they expanded it, but partly because of attrition and because hospitals can afford to pay them, you know, a lot more and give them a signing bonus, which is good for social workers, by the way. This is great news for social workers. But I also want to, like, the flip side of that coin, which is we're never going to be able to treat ourselves out of this problem. And so when you think about resources, it's like, sure, let's add 60 child psychiatrists to our state. We also know from NVDRS and from other sources that a lot of these young people never did receive any kind of mental health care. They weren't not even referred to a mental health care provider. So would that death be preventable because we had a child psychiatrist who could see them tomorrow? No.
Well, I think we've had a really great discussion here, and this is actually our second webinar where we focused on talking about mortality reviews and really expanding it, because I think this is a very important topic. I know we can all agree, especially the panelists here, because you're there, you're working, you're doing, and you're changing our states and you're changing lives every single day. So I want to thank you all for being here. I do have a couple webinars that I would like to share with everyone. So you have other opportunities as well to get information. Up and coming through SAMHSA's Financial Resource Office, there is some grants webinars. So there's 3 separate dates that you can sign up for. There's one in August, September, and October. They're all at 2 p.m. Eastern time. There's a link with more information, which I will toss in the chat as well, so you have it. And also through the TA Center, we have our community of practice priority groups. So if you are not already on the list and need more information, please contact us. But once you sign up, each priority group will continue to have meetings, and you'll get all those reoccurring meetings. So our first priority group met on August 2nd for identifying SMVF, and the screening for suicide risk will meet September 7th. Priority group 2, the connectiveness, will meet on August 4th, which is tomorrow, and then care transitions will meet on September 1st. In group 3, lethal means safety and safety planning, lethal means will meet on August 5th, and safety planning will meet on September 2nd. So I wanted to make sure to share that information with everyone, so you do have that, and you know that we have more events coming up. I want to thank everyone for being here, especially our fabulous presenters with all their expertise and knowledge that they're willing to share with us and answer questions. These webinars and the slides will be available in a couple of days. It'll be posted on our YouTube channel if anybody would like to go back, and be shared with registrants shortly. If you have questions, again, please reach out to us. Thank you so much to our presenters, and thank you to everyone who participated today to learn more and grow more. And I hope that you're able to take this information and impact change within your own state to save lives. Thank you so much.